Morning, everyone. AU Patient Summary FHIR IG call. We're getting really into the need of preparing for our ballot for comment going forwards. So I'd like to start with an acknowledgement of country and that we acknowledge the traditional custodians of the lands in which we all gather today. We pay our respects to elders past, present and emerging, and extend our respects to all Aboriginal and Torres Strait Islander peoples. We acknowledge the First Peoples as the first scientists, educators, and healers. The agenda for today's call is through usual business, but then we're actually going through the walkthrough of the profiles. We advertised that sort of in our last call of some of the things we need to do to go through our baseline and prepare for putting out a ballot for comment. And we also have some use case design decisions that are coming through. And then we'll talk about next meetings at the end. But really, we're starting to just go through these. We have, I think, about 18 profiles in AU Patient Summary, and we're going to cover them all over the next 4 weeks. So that is really looking like something like 10 minutes a profile. We'll see how we go. This is a reminder. This is what we're preparing for. So we're starting with looking at our ballot for comment scope. We're going to progressively inspect all our profiles that are there that currently represent our agreement of Australian Patient Summary is going to comply to IPS and it's going to comply to AU Core. I'm going to go through and have a look at that and ask some questions. What's missing? What's going to be a problem to implement? What feedback do we need to provide back into IPS? What feedback do we need to provide back into AU Core? And where else do we want to go with this content? And of course, there's the use case content. This is under construction. We're building that in each call. So let's get through usual business. First off, as always, is minutes. They were sent round last week. I'll just go to those. Oh, and I'll also note in the chat that the slides for today's meeting are on the agenda. Dushi's popped the link to that in the chat. So these slides we're walking through now are already there. But here are the minutes from our last call. So we have all the attendees listed. We have both the slides and the video, along with the transcript and chat log. And then we have here our set of minutes of what we walked through and where we made some decisions. There's no feedback outstanding, but does anyone need any more time to review this before we look to approve the minutes? All right, I'm not hearing anything. I'd like to entertain a motion to approve the minutes. I'm looking for a motioner.
Move to approve.
Mm-hmm.
And
Thank you, Stephen.
Second,
thank you, Shelley. Shelley's seconding. Are there any other comments or questions while I'm moving to the electronic poll? Okay, you should see popping up in front of you the electronic poll. If you can't vote, possibly because you're co-hosting like Steve, then you can put it in the chat. If you've dialed in and you don't have access to the chat, you can say your name and whether you are affirmative, negative, or abstain for those. Okay, 80% have voted. So I'm now going to count that down in 5, 4, 3, 2, 1. I will end that poll. I'll share the results, including what's in the chat. We have 15 affirmative, 0 negative, 7 abstain. The motion carries. Those minutes are approved. Thank you, everyone. Okay, back to this. So actions, there were none. We have no open actions out of our previous meetings. So let's move on to updates and news. It's relevant to us that in yesterday's AU Core TDG meeting, they voted to add must support to immunization.lot number. And that comes into the AU Patient Summary Immunization profile we're about to look at today. And it's also worth noting that Conformance Fridays are back. And this time, they're focused on patient summary. So in terms of Conformance Fridays, the discussion, or I think the call that was put out in our last meeting, is that we're intending to hold some optional fortnightly discussions. These are kind of like a focus group for those people who are interested in conformance, like me, and who want to work on the proposal for what will be the conformance requirements in AU Patient Summary, answering things like, what does my support mean? What does it mean for us to be downstream, both AU Core and IPS? What are our obligations? And so this is optional. A meeting invite was sent out for a fortnightly series to the project mailing list. If you aren't on that yet, if you want this in your calendar, you can contact me, or you can email sparked@csiro.au, and that meeting series will be forwarded to you. This is optional. All of this will be recorded and made available on YouTube anyway, so you can come back and look at whatever conversation is happening if you miss anything, or if you just sort of want to stay in touch. But the outcomes of that sort of subgroup will be coming to this call. They're going to put together a proposal, and that should come to this call in July to consider an initial proposal for AUPS conformance that we'd like to include in the draft that will go out for ballot for comment, so we can seek wider community feedback on what that looks like. Are there any questions about this? All right, I will note one thing. The specific time for the fortnightly session. So today, this afternoon, there is the 101 conformance. So that's kind of, if you've not been involved in these before, or you just want a refresher, or you want to learn more about conformance in FHIR, there's a 101 this afternoon. And we can put the location details for that in the chat. I think Dushi or Heath, if you could drop that in the chat around the Zoom link for people and the time. And then otherwise, I think we're looking again at a particular time for the fortnightly series going on. And there's currently a Zulip poll. Could I also get the link for that in the chat, please, so that people can confirm what time, if they're interested to come to this meeting, works for them. All right, I'll move on while that's happening.
Yeah, I'll do that now. Thanks, Daniel.
Thanks, Dushi.
I'll get the Zoom if you like.
All right, so Heath will do the Zula. Dushi, can you put the time of the meeting today in the Zoom link for it?
No worries, doing that now.
Last kind of update, the Spark testing event. This is going to be on the 24th of June. This is a combined event. So it is a one-day testing event in Brisbane that includes core, summary, and e-requesting. A reminder, registration closes next week. This is for those people who either have a product already or are in the process of building a product that includes FHIR, whether that's just the data, which is also really valuable to bring along, which allows other people who are building facades or have servers or apps to be able to try to access that data. We can host it on a server. That shouldn't be a problem. So I would recommend that if you are looking at how to build out or test this, and you can be there in Brisbane, because it is in Brisbane in person, then come along to this event. Reminder, registration closes next week. That's a hard close. All right, let's go through the profile walkthroughs. So based on feedback last week, you will note we've changed the icon, which confused everyone with bugs and ticks altogether. And now let's look for gremlins. So we're starting with patient, immunization, condition, and allergy. The ask for people from the last 2 weeks was to review those, and the links to them were put out, and to bring your questions around what in those profiles just isn't making sense to you. What do you think will be a challenge to implement in Australia? And therefore, kind of where are we going to provide that feedback? Is this something that is imposed by IPS and we need to have that conversation is this something that is imposed by AU Core? And we need to go through and see if we can address that in AU Core R2, which has still a few more meetings in which the feedback can be provided. So we kind of want to get on top of that. And we also want to know what's missing that you're relying on. Where do we need to say in Australia, these are the additional things that we need, that is in addition to what's in core and what's in IPS. So that's this look. It's these 4 profiles. We'll keep going through the rest of them through the rest of the meetings. And I just want to remind everyone, the profiles that we put out in Patient Summary are essentially us saying, these are the minimum expectations for a FHIR resource. So the minimum in a FHIR resource in the context of a patient summary in Australia. That's essentially what those profiles are to do. So, quick recap. We have a set of agreed principles that we did back in December. And we have 3 of these that we shall validate. So when we have an AU patient summary profile, it shall validate, the resource shall validate against both IPS and AU core profiles. Like when both are available. If there's only one, it's that one. And that means that we take into account things like cardinality, must support flags, terminology, fixed values and patterns. We look at our data types, profiles for different references, and things like invariance or other kind of conditions and rules on the behavior. We're expecting that we will validate reference elements against the patient summary profile. So we've got an example here that the reference element for subject would be to the AU patient summary patient, not just the AU core patient, not just the IPS patient, but the AU patient summary patient. And that where we've got 2 value sets, like 2 preferred value sets or 2 extensible, we prefer the core value set over the IPS value set because that brings in the bindings and the localization from Australia. Examples there are having like AMT vaccines over WHO, like WHO's vaccines. So that's our design principles that we've carried forwards into the current draft. And our current draft, we did a very quick walkthrough in February, is that the current authoring approach of our FHIR profiles is optimized for the human-centric view. So we've manually authored all like the calculated rules of these 2 into the profile. I'll show you what that looks like in a second. We don't have any additional rules yet. So everything you see in the AU patient summary is literally either imposed by core or IPS or both. And you can see that in the diff view of the profile, what that set of rules is altogether. We're not including obligations in that view yet. That's a separate conformance conversation, and that's like the optional subgroup that's going to work through that. This is about the rules on the data itself, cardinality, terminology, etc. When we've gone through these rules and looked at where are we happy with this? Do we want any additional changes? Do we want to undo anything? Then we're going to move away from full manual authoring and probably end up deriving from AU core. That's kind of what we talked about, saying, I want to be able to see that if I have implemented AU core, what else do I have to do? So that's the current draft and what you can see in it. But let's get into profile walkthroughs. Are there any questions before I kind of go into it and show you what I'm talking about? In chat. Nope, good. Okay, let's go. Let's start with patient. This may be the easiest or the hardest, who knows? So, patient profile. I'm going to start with the AU core profile comparison. Most of the people on the line here are aware of AU core patient, are in most of those calls, in fact, have ballot comments on AU core patient in the past. So, we've looked at AU core patient and if there are any additional requirements, and there are additional requirements imposed by IPS. They're only on 3 elements where there's an additional requirement in patient.name, an additional requirement on contact relationship, and on general practitioner. I'll just click through to the profile comparison. Actually, I'm going to just bring it up here. So if you go to AU Core at any point in time, it has a comparison and it has a table where you can see if I implemented AU Core, are there any additional requirements? Is there an incompatibility, or is it like compliant? So this is there across both IPA, IPS, and US Core. So for patient, we've got here, there are additional requirements, and this shows what those are. That's where I've got this from. But let's have a look at the profiles. Now, my thought was that I would show you IPS, then I'd show you core, then we could just look and do a quick walkthrough of the profile. Or would people like me to just go straight to the profile and simply talk about where each of this stuff comes from? What would work better for people? Assuming you have an opinion on that. I think because this is our first one, we'll see how it goes. All right, can I ask, is this font size big enough, or would one extra size be more helpful?
Yeah,
One extra size would be more helpful.
Yeah.
All right, let's do that. Okay, yeah, is that good?
Yeah.
Okay, cool. So this is the AU patient summary patient. Okay, that's what it is. This is the full set of rules in the differential. It derives from AU-based patient, and we have manually added the rules from core and IPS. And that includes copying the invariants in. I'm going to walk through these now. So I'll come back to the invariants when we talk about the element in particular. For patient, here's what the rules are. We have must support on Indigenous status, gender identity, and individual pronouns. These are AU Core and post rules. So AU Core puts must support on these three. We inherit that in AU Patient Summary. IPS does have gender identity and individual pronouns in it. It's just not must support. So if you saw, this is IPS here, you can see these two profiles, these two extensions are there, but they don't have must support. So that's where the extension must support is coming from. That's coming from core. I'm going to keep running through this. And what I'd like people to do is where you have a question about an element or where you have a comment. So if you want to raise that something that you think is missing here or that something is challenging, can you put your hand up in Zoom? Or if you've dialed in, just call out your name and we can stop on that particular element and capture the discussion there. So extensions. Any questions or comments on the extensions? All right, let's move on. Let's talk identifier. This is almost entirely imposed by core. So in AU Core, we have identifier as mandatory, and we have these three that are must support. So these come in, all the data types, all that kind of thing comes in from core. We've got a hand up. Perfect. Who's got a comment?
Daniel, just a question about the first extension. No, sorry, gender identity.
Oh, yes.
Not been included, and correct me if I'm wrong, it's not there in R1 patient or practitioner, but we are discussing it in patient summary. Am I mistaken
It
here?
is in AU Core patient. It is
Okay.
here. That's where it comes from.
Okay.
Yeah, so at the moment, what we're seeing in this profile is in this profile, it's all in AU Core R1. Liam.
Yeah, thanks. Apologies if I missed it, but you're manually copying in the constraints from AU Core, but deriving from AU base. Are there things from AU Core that we don't want to copy in, and that's why we're deriving from AU base? Or why wouldn't we derive from AU Core?
The current current profile design for AU Core is solely for the walkthrough. Sorry, the current profile design for Patient Summary is only for the purposes of the walkthrough. So we see all the rules in the diff. It will change to derive from Core after we've done these human-centered kind of walkthroughs.
Okay, thanks.
No worries. So extension usage, totally imposed by Core at this point. There are other extensions, they're just not must support. There's the usual AU-based ones. In terms of identifier, it's mandatory. We put support on IHI, Medicare number, and DVA. That all comes from Core. So they're here in Core. This is where this all comes from. IPS does have must support on identifier, but unsurprisingly, it does not have must support on IHIs or DVA. We wouldn't expect that. That's an Australianism. It's coming in from Core. There is another rule on identifier, again from Core. We expect that at least one identifier is valid. Or if it's not available, you've got a data absent reason extension because the missing data rules apply. So you've either got something that is valid according to the rules of Core, or it's absent. That's identifiers. Is there anything people think is a problem here from a patient summary perspective? All right, I'm going to roll on. Let's go name. This is a little bit different. There's a combination of rules there in name. We've got ones up here from patient, from Core. So in terms of name is mandatory. And Core says you can have text, family, given, or DAR. IPS is stricter. IPS says every time you provide a name, it has to be given, it has to include given, family, or name.txt. So you can't use data absent reason on name. So the combination of both Core then, which is setting the cardinality rule, I think IPS doesn't. Let me just have a click. So IPS, oh no, it already does. So IPS and Core share the cardinality rule of minimum of 1. AU Core allows data absent reason. IPS does not. So therefore, in AU patient summary, you must always supply at least one name that has family or given or text. Is that a problem for people? Sorry, I'll come back to this one. Are there any concerns there? Are we happy with that? I think that makes sense in the context of patient summaries, but the point of this is to run through and flag anything. All right, let's move on. Telecom is optional, must support. Gender is must support. It's a minimum of 1. This is a rule set by AU Core. It is not in IPS. Let me just come down. IPS has optional and must support. Stephen.
Yes, I would like to raise an issue on the gender element 1.1, which I have actually logged a ticket against AU Core. This constraint is, I think, 2 types because of 2 reasons. Number one, if we can't find any value in the value set itself, which has a required binding, then we are forced to use unknown, but unknown might not be appropriate. And also the second reason is that we have gender identity. If we put unknown here, and then we use gender identity for a value that we want to, then we have confusions in here. So there is a gender identity extension which we can use. So if we can't use the patient.gender and we put unknown in here, and then we try to use the extension and put an appropriate value there, or because the binding is example binding, in my with my recollection. And if we replace it
No,
with
it's extensible.
extensible, if we extend it and then put a new value in there and then use that value, and that value will conflict with the unknown, which can cause confusion. So therefore, I don't think that tightening tighten the constraint to 1.1 is desirable.
Okay, so 2 points there. One, can you contact the AU core coaches to make sure that you have that issue you've raised for core on their agenda list, so that we can schedule that and alert people, and then we can discuss whether or not that comes undone in core.
Okay.
And can I ask if there are other people on the line that are also going, yes, I think that expecting there to always be an administrative gender, and I'll come back to I don't actually think what you've described in terms of gender identity is a problem. They are semantically different elements. This is administrative and is used for like patient matching identity purposes, and the social construct of gender identity is not. So I think it's totally fine that one would have unknown and the other would actually have and gender identity might actually have a very specific value in it. I think that's fully acceptable.
Yeah, but the semantic similarity is likely going to cause confusion. So I'll raise this for discussions at the firework group for that. But yeah, just want to register it here as well.
Yeah, and I think it is. That's a good point to also raise it in the firework group. AU base says that these are different things, and there's guidance on that. Not very clear guidance, so it could be clarified further. That would be good.
Okay.
Also, sorry, Brett, you've had your hand up.
Oh yeah, no, I was just going to go. I was going to agree with you there. I think we can handle this back in the other committees because it's really a intrinsic usage question. So I don't think it's a patient summary thing to solve. We're kind of inheriting it here. So
yeah, Brett, I'm not saying that patient summary should solve it, but I'm just saying given that Daniel asked the question, is there any issue? I just want to raise it as an issue.
Yeah, and I just want to question there the issue. Okay, so there's one thing to have the issue in the core, but the issue you're raising, Stephen, is that for patient summary, like I guess that's the driver, that for patient summary, gender should be optional.
Yes.
Yeah, and I think AU Base attempts to do this with there is a sex and gender guidance page in AU Base which attempts to explain the usage of the extensions and elements as well. So I think
all right, in the interest of time,
we should get that fixed if it's not saying.
There's an action on Stephen to contact the firework group co-chairs and get something on the firework group, AU-based conversation, also a separate action on the AU core co-chairs to get this discussed for AU core to relax the cardinality. And Heath, did you still have a comment that you wanted to make?
No, it's okay.
Okay. All right, let's go next one. So we've identified a potential thing around gender, and we'll do updates back into this group about how those conversations go. Birthday, must support mandatory. This is in both core and IPS. Anything about birthday? All right, let's go address. Optional, must support. Same in IPS and core. Nothing particularly interesting there. Okay, contact relationship. This comes in solely from IPS. And so AU core silent on it. IPS has this, where they apply a codable concept. This codable concept is on contact relationship, and it has must supports, but inside the data type. So I think that can be interpreted in some ways. We might have to ask for some clarification a little bit and get a presentation from either Stephen or Heath, who attend these calls, on what this means. But just note this is here. Does anyone have any comments on contact and contact relationship?
So is that's just saying you have to have because it's bound, you have to have a code, whatever's defined in that data type.
Well, you don't have to. Cardinality doesn't change. It places obligations.
It's just must support.
Yeah, but yeah, okay. What does that mean? Yeah, okay.
That's
Well,
kind of what I
yeah.
was thinking is let's not do it now,
Yeah,
that we
yeah,
will get a
cool.
presentation from
It's in scope. Talk about it.
one of the folks to talk about what it means.
I'll go
So-
through this next week probably.
Okay. And some of that will come out of the conformance sessions, actually.
Yeah, there's one. I probably can focus on that one maybe next week because I'm talking about IPS conformance next week.
Okay. So stay tuned to the optional conformance sessions if you want to know what that means. All right, let's talk communication. This comes from AU Core. We have must support and optional, which allows for the indication of a consumer's preferred language and supports saying, you know, we need an interpreter and here is the interpreter language. So that comes in from Core. And then we have this last one, and this is general practitioner, and this comes in from IPS. It's not in Core, which says for patient summary context, we put must support on general practitioner. There are no other rules other than putting must support on here. So it doesn't restrict data types or cardinality. Okay, last question, folks, about patient. Anything in here missing? Things that you want or rely on that aren't present? Okay, I think we can consider that first pass reviewed. And we've got a couple of actions there to follow up some things around the use of patient.gender and gender identity. Let's go on to the next one. So the next one in my list, if I just go down to it, is immunization. So immunization does indeed also have additional requirements. A lot of these are that codable concept IPS, but there is a difference here on referencing. So let's go have a look at it. I'm going to do that by doing this little shortcut of just typing that in. So immunization fully covers IPA, doesn't cover everything in IPS. Here it is. We'll come down. All right, status. Status as in, was this actually administered? Was it not administered? Is this a record that's entered in error? Is must support? And I'm just going to keep going through these elements. And if there's any comment you have, pop your hand up or put it in the chat. Let's check the chat now. That's just mostly links. There we go. Okay, next bit, vaccine code. There's a few things coming in here. This is indeed must support. It's must support, obviously, in both IPS and core. The codable concept IPS comes in from IPS, which is also where we start to bring in coding kind of rules here. Now, what we've got is these slices for terminology. The slices for terminology come in from core. So this is where we've localized. We've got AMT, we've got AIR. And they're the two recognized terminologies from AU Core that we have placed must support obligations on. And we have also, in Core, set the max to be 1. So you can only supply 1 AMT, you can only supply 1 AIR code for a vaccine in an immunization. And these are the bindings maintained in the NCTS. All right, let's move on to patient. So in patient, which was already mandatory. This, points to our AU patient summary patient. So that's the profile we just walked through. That's what this points to and says any resolved patient needs to conform to this profile. It's mandatory. You can only have one of them. That is the same in both core and in immunization. What comes in from IPS, so in terms of a patient summary context, and this is much more of a document context, is it says you need to instantiate reference. So it's not just a logical identifier. It's not just a display that might just say Bob. In this case, there is an expectation, there is a reference to a patient resource. That's the requirement there. That comes in from IPS. Brett.
Yeah, because I mean, we know there is a patient in the composition, so there is always one to refer to, which is different than core. No, it has to be, because that's what the composition says, right? So that we know there's always one. So I think it makes sense in the summary context, right, that we would refer to it.
Yeah, that's right. Patient summary is designed, or it's defined as a document. And every single one of these, you'll see this on condition, allergy, and tolerance, will all have the patient reference pointing to, like they will actually have reference, both composition, and it'll be in all the clinical resources as well, because that's the expectation, that it's all pointing to that patient. And in the bundle that it defines the document, you can only have one patient resource. It's always going to one specific resource. Okay, next bit, occurrence.
Oh, so just going back, so that effectively means you couldn't do logical. Well, you could do logical as well.
Well, you could both.
Yeah, as well. Yeah,
yes,
exactly. But not only logical. Yeah.
Yeah, and for those people on the line, logical might be, for example, if you identified a patient by an IHI, but didn't want to maintain references or wanted to do both, you could have a reference which would point to maybe a server specific thing, or like a local or a literal reference. And you could also have an identifier, which would be the patient's IHI, for example, but that would have to be additional, not instead of.
So to be an IPS, it has to be referenced by value and be contained in the bundle. Yeah.
I mean, theoretically, I guess once you consume it, you could undo all of that. Obviously, you might process it, pull it apart, go off and do various things to it, and you would likely replace those references depending on like downstream. But for the bundle itself, and then when you persist that bundle, that is the expectation.
So it's self-contained, and you will have patient details always. Yeah.
Cool. Yeah, that's right. Does anyone have any questions about that? That'll come up a few times. So I think, thank you, Brett, for bringing that up. It is one of the big differences in design between patient summary versus other use cases. All right, next, occurrence. So this is the administration date, or I guess theoretically, if it was actually not done, that might be the date at which you intended to do it, but the patient may have not shown up for the appointment, or may, for example, have refused for various reasons, or it may have ended up being contraindicated to something. So that occurrence is associated also with status. This has must support. This comes in from the FHIR standard. So that cardinality we can't change. It can be a date time. It can be a string. Both are allowed. All right, primary source. Primary source must support. That indicates the context. I honestly don't remember if it's in IPS. Let's have a quick look. It's not. So this has come in from AU Core. It was specifically added in the last ballot because it's important, and generally captured as well in terms of how we report immunizations in Australia. If I just go to snapshot, primary source. This allows you to say things like whether or not it's actually from the person who administered it, and or whether or not it's like secondhand reporting of information. So that's what that value is. Brett.
I just wanted to go back on occurrence in IPS. There's a must support on data absent reason.
Yes.
As an extension.
Yes.
So do we kind of consider that covered due to the AU core?
Yes.
Topic for another day.
Yeah, but anyway,
no, but that is
yeah,
true. Sorry.
Yeah. So it's not explicitly stated there. Yeah.
So the rules from AU core on missing and suppressed data apply. So everywhere that you can apply the DAR extension according to missing data applies. Though, yeah, that's kind of, we're going to double check all of that through the conformance sessions. But yeah.
Cool.
It's topical
so
in
effectively
IPS at the moment.
Right. Cool. Thanks.
No worries. So yeah, according to the rules, the fact that because this element is mandatory, absolutely a data absent reason extension can be supplied instead of, if you don't actually know the date, don't have a way to describe it, you can use a data absent reason extension to indicate unknown. Primary source, if you don't know it, because it's optional, you leave it out. That is in accordance with both IPS's rules and AU Core's rules that are synergistic. So both AU Core and IPS talk about the use of DAR extensions where something is mandatory and it's not codable. And that when it is optional, you just don't include the element, basically, if you don't have the data. Okay, so then we come down to site and route. Now, there's only a couple of things shown in this because we are deriving from base at the moment. So site, codable concept IPS is in play, and also so is the terminology. So we have body site terminology that is the reference set that is maintained in our NCTS in Australia. And Brett, is your hand up from previously or? Okay, yes.
Yeah, it is. Sorry.
Yep, no worries. So site is coming in from the Australian definition of that terminology. If we come down to site, I've just gone to the key elements view here. And so that goes off to immunization anatomical site, which is a maintained set by the National Clinical Terminology Service. So while we don't see it in the diff, we get the localized Australian terminology coming in from AU base. Brett, your hand is back up. Is this okay?
This is back up. Yeah. So that means what we've just swapped out the preferred binding from the IPS preferred to our preferred.
Yes.
Effectively, yeah.
So we have a localized in Australia value set that is maintained for sites, and it includes Australian specific values from like our Australian SNOMED CT AU extension, and that's what's maintained.
Yeah.
So at the moment, that's the one that would go in our profiles over the one that's in IPS, if you wanted to see it, where site is this one. So it's IPS hasn't done a specific one. They're just inheriting this from the base FHIR standard. They haven't localized it for patient summary. And in Australia, we've localized the FHIR standards body site, which is every body site ever, including like eyes and all sorts of things, to actually be about immunizations. So we've got the localized set in our profile. I think that's the right set, to be honest, to have the local one that's about immunizations. There's some wacky stuff.
That's our general one, right? Anyway, that we apply to body
No,
sites.
literally, it is actually defined and agreed for immunizations.
Ah, okay.
Great. Yeah. It's a really nice, concise set of only 15
excellent.
codes that support specifically vaccination locations.
Terrific. Good.
So yeah, I'm all for keeping it, but over the generic, non-specific one. If we come back to
So does that mean that when we're generating a patient summary that would be used as an IPS, it's going to be important for us to have a display text associated with that so that other people can understand it?
Well, that is a question about obligations, not about the value set. Value set doesn't say whether or not you have text associated with it. The value set is about the codes.
Yeah.
So ask your question again on
usable.
Well, yes. To ask your question again in the conformance sessions, because that comes into this data type and why it has must support on different things and what does that do. That's a conformance thing. So system behavior.
Yep.
But you don't have to do it at all because it's not the actual element's not. Yeah, but if you do, you would need it. You would expect the text. Yeah. Is that right?
Yeah, it's worth calling out, and we'll have to have a convo on it, that this one, this codable concept IPS, has must support on the element itself. So the concept of the vaccine, identifying the vaccine, has must support. The concept of body site does not. So these parts of the data type, obligations start to kick in if you have, independent of the rules in this profile, decided you're going to provide it. Then you've got some obligations on you. Now that again, it's the fun conformance conversations. I'm going to be part of them. It's always tricky, you know, logical arguments. We're going to have to talk through it. But that's a different convo. So site route, same thing. We have in Australia defined terminology. That is what is currently being applied. Let's go have a look at it. We'll scroll down again to route. Here it is. It is localized and is specific to immunizations. So we've done that. It's maintained in our National Clinical Terminology Service. And that overrides what was preferred in IPS, who has this one, which is in this case, unlike the previous one, an actual IPS value set. So here there is a IPS value set. This is medicine route.
That's worse than yeah, no. There's tickets against that because that's the European standard for
Oh yes.
Yeah, which is not ideal.
So yeah, it's not a SNOMED. This is, as you pointed out, a European terminology. I don't think it's implemented in Australia. Whereas our current set that we would have in Australia for patient summary, and it comes in from base, is we have an agreed SNOMED set for this content. I'll just bring it up here. That's what this is. Here we go. There we go. That's route for immunisations managed in Australia. It's still only preferred, but it's not stronger binding. It's a preferred set. So that is that terminology. Let's just double check. I think I've got one more thing to talk about in. Apologies. Trying to click through in an efficient fashion. Let's go down. So that's route. And then we have, oops, let's just do differential so that we get there quicker. Then we have note. Note must support. Now, note must support optional, multiple. This, if we look at IPS, isn't coming in from IPS. It's coming in from AU Core. So we have set note to be must support in AU Core. That's where we do that. We inherit that now. And that comes into AUPS. So Australia's patient summary now puts must support on note. All right. That's what you get in Australian Patient Summary Immunisation. That's the rules. So I guess same questions.
Oh, I got
Yeah.
a question. So we're not going to list the protocol applied preferred binding from IPS.
It's not a rule in IPS.
It's not. Yeah, it's not a rule as such. There's a candidate.
No,
binding.
we aren't. We aren't
Yeah,
doing that.
yeah. So there's no actual.
Correct. There is an Australian one. The reason it's not changed here, sorry, is there is an Australian preferred binding again. So for a whole bunch of other elements. Really? Have a look at base.
Oh no, we do have one. You're right.
Yeah, that's right.
Yeah, yeah.
So again, there's no extra rule written here because we inherit from AU base.
And there's no other rules.
Australian maintained value set there.
Great. And they don't have any other constraints, so we haven't listed.
Correct.
That's good. Yeah, no, it's cool. Thanks.
Thanks for calling that out. I forgot about it.
No,
There's a reason you didn't see it.
Helps me understand. Yeah, good.
Okay, does anyone have any other comments or questions about the Australian Patient Summary Immunisation Profile, including that they thought there'd be more or that they would actually like there to be less? All right, we're going to get through one more. Let's have a go. Can I ask, condition or allergy intolerance? Which one should we go for? I'm just going to go condition, allergy intolerance, thumbs up in the chat, the one that you would be more interested in. We can only do one in the time remaining. 10 seconds. Michael, you've got to use thumbs up. Perfect. Okay, we're getting there. Thumbs up. The two chats. 5, 4, 3, 2, 1. Condition wins. All right, let's do condition. While I'm typing these in, can I just ask, does anyone want me to be doing something differently than what I am doing? There's multiple ways we can show this, and hopefully this is helping the way that it is being done. Very open to other approaches. Let's have a quick flick back at the slide. Condition. Here. There's some differences. They are actually kind of minimal. There's a bunch of where codable concept comes in, because IPS is essentially setting codable concept IPS as the data type on just about anything that's sort of vaguely relevant. So it'll come across a lot. The two that we really care about, and we just talked about, was subject.reference back in immunization, so same deal. And then here we've got a new thing on onset. This is going to be another thing that I think is weird, and we're going to need to ask them to explain. But let's go through it. So condition. Come down. We have essentially these elements as must support. There's a great deal of similarity between IPS and AU core. And in all of these circumstances, we are basically using AU core's terminology. So there's nowhere IPS has put terminology that we don't, that we haven't already localized in Australia. But I think there's a potential for one of them to look at adopting IPS. I'll get to that in a sec. So clinical status, verification status. The only difference is this has must support, essentially. If we go look at IPS condition, they also have must support on clinical status. They don't have it on verification status. AU core has it on both. That's the difference, really, between those two profiles. Oops. So we, therefore, get it on both here. For category has must support, That's the same in both core and IPS. This is cardinality of 1, so you have to supply a category. You have to say it's a problem list item or an encounter diagnosis or something else. The terminology sitting behind this is extensible. We're inheriting it from base. It only has 2 codes that come from the FHIR standard. So in AU Core, there is an extensible value set that we inherit from FHIR that says problem list item or encounter diagnosis, and it's extensible. In IPS, they do something a little bit different. In IPS, the category is restricted, sort of. They have created a problem type IPS, which lists just problem list item. So it's one of those 2 codes. The binding is still extensible, so any use of another code, including encounter diagnosis, still passes validation. It's still compliant to this profile. And I have a question posed to this group. Do we adopt the IPS value set where we just say problem list item or something else? Or do we keep it to being the, inherited value set, which says problem list item, encounter diagnosis, or something else? Now, we've got a hand up. Sorry, who is that?
It's me.
Ah, Stephen. Sorry, I couldn't see who it was.
No, that's fine. The question is, why do we want to force a cardinality of 1.0 for category? I can't see any business or clinical utility to force that cardinality, given that internationally they don't even need it to be mandatory.
That would be a core issue. You can raise it in core. I will state that there is more than one section in patient summary that has conditions. They are differentiated by a categorization. So it helps a machine to say that your problems, your current problems, pull in everything from problem list item, and your others, like past history of illness, don't put things that are currently categorized as problem list items in there. So there's some reasons why that is in a core condition that is minuted, which is about the machine processing both for searching and filtering that allows that kind of differentiation.
So you're basically forcing people to put a no data flag into it if they don't have anything. What is the utility of forcing people put in a no data flag into it when in a lot of the cases they might not even have it?
No one has reported an inability to complete that. We've had a lot of testing from most of the GP desktop systems and some of the other content, and no one's reported any problems with completing that element. Though, should they raise it, that would be a good point. So I think it's theoretical at this point that they might not be able to.
Well, it's not theoretical. Based on the international discussions, a lot of the implementers have reservations on this. I mean, I'm not saying that in Australia it would be problematic, but I think there is a reason why at the international level they don't tighten the constraint that much. And I'm not sure that there is actually a good justification to force it to have a mandatory requirement.
Again, it's probably a conversation for core, but I mean, the way that a lot of the systems work is that they store different types of conditions in different modules. So whether it's an admission condition, for example, versus something that's a reason for encounter, etc. So they're just the way it's managed internally quite often, and it's helpful when it comes to things like searching, etc. As Danielle said, to be able to even populate this particular section, to be able to put some criteria on category to do so.
So I guess currently we're inheriting this from core. the conversation has been had in core and it's set there, but it can be revisited in core if someone wants to raise and suggest why this isn't working or is too restrictive.
Yep.
In terms of terminology, we might revisit, because I don't know if we have time, on whether we keep the problem list item encounter diagnosis or something else value set, or whether we adopt IPS's problem list item or something else value set. It's a little bit swings and roundabouts because in the same terminology rules apply anyway.
I think
so. Let's maybe, yeah.
I would just go with what we say in AU core, since the rules don't say you can't. It's like yeah, I'm not sure there's any point to restricting it to the IPS set.
All right.
Is
But
there an
that's just-
explicit binding,
yeah.
or is that just a description?
No, there is an explicit binding. There's
Yeah,
two
there's
value sets, both extensible. IPS takes the. So I was just keeping this here because those are the two codes that are present in the extensible binding.
And I think they're key
IPS,
codes as well. So I
They
agree with Brett.
But well, they're the only codes, right? And I mean, they're the ones that AU core recognizes. So they're just the ones you get in the resource, right? It's
yes.
So it's definitely fine to use encounter diagnosis because it's an extensible binding in IPS. So then you just go, well, why would I not tell you that?
So is this profile only used in the one section, or is it used in other sections as well?
It's used in other sections.
Yeah, okay. So then we need it both.
Yes. Okay, so I'm hearing let's leave it for now. If someone would like to raise a potential change, they can, but let's leave it for now. Let's move on to severity. Severity is there. It's must support. We haven't changed the cardinality. That is FHIR's binding. That's also come in really from FHIR. If we look at IPS, you will see it's got exactly the same thing, except that this is preferred. And in AU core, if we have a look at severity, that's where you get extensible. So the same binding, the same cardinality. Oops, sorry, wrong tab. Same binding, same cardinality. The difference between IPS and core is this binding strength. When we come to code, both IPS and core have this. It's must support. Obviously, we get this data type from IPS. This is an Australian binding. So this is managed again through the National Clinical Terminology Service of clinical conditions, which comes really from the reference set. So that's what is currently set. We get that from AU core over the IPS binding, which is the international definition of that. In terms of body site, we get this data type from IPS, and this is an Australian binding. And we also get this invariant. So AU core, and this has been talked about in a couple of meetings, and we keep landing on this, that if you're coding a body site, at least one of your codings is going to be SNOMED. You can provide others, but there's an expectation that if you're coding body sites, you're providing SNOMED. So there's an invariant there, and we would inherit that in AU patient summary. When we come to subject, same thing as in immunization, goes to the AU patient summary profile, and it expects you to actually provide a reference off to your resource, which is expected to be in the bundle to be compliant to patient summaries. Then we come down to onset and abatement. It's a little bit different between core and IPS. So I believe it's only core that has abatement. I'll just double check that off the top of my head. Yes. Okay, coming back. So Core is where we get must support around abatement, and both IPS and core say something about onset. They say slightly different things, and we might need to resolve this, and this is a topic for our conformance. Core says onset. Give me information about onset if you have it. It's fine if it's just date time. It's fine if it's age. It's fine if it's period. It's fine if it's range. Like if you can only say, I was 12 to 14 when this first happened. IPS only has must support on onset date time. There's a difference there. And I think we'll have to explore that in the conformance area. And then for abatement, and this comes in from core, again, it says if you've got information about abatement, well, this is must support. It could be any one of these data types. There's no further rules on that. So that's what's happening on here. And then we have note. Note doesn't come in from patient summary. So IPS doesn't have any rules on note. AU core does. It's a little bit controversial that core sets that rather than a downstream IG. But our last position has been that, yes, we do want to retain it. So that's coming in from core to say, no, must support. I'll just double check that. Is that really there? So we do keep arguing about it. No,
Yep,
no, it's there.
yep,
Okay, cool. Yep.
yep.
Okay, good. So that's that. That is condition. Before we close this segment, overall, is something missing that you rely on? Are there going to be problems trying to implement some of this outside of we noted a category one, potentially?
We're going to go through in conformance the onset date time. What does that mean?
Yes.
Question. Yeah, cool. Because I think that's one that's come up from US core comparisons as well. Yeah. Cool.
All right. So I'm going to stop this walkthrough. We got through quite a bit, not quite all four. And let's go on to our other topic. We'll hold over allergy intolerance to the next, to a later meeting. And we'll go to use case decisions. Now, Shelley, did you want to share your screen?
Yep, I can share my screen. Won't be a sec. Oh, I haven't got a share button. Oh, there it is. Fabulous. Hopefully everyone can see that. Okay, so I'll get through this quickly because we don't have a lot of time left. So basically, we just want to keep going on the use case design decisions for the AU Patient Summary FHIR IG. So we've made some good progress and we're just going to keep refining and aligning on the remaining questions that we've got. So quick recap, at our last session, we made the agreement to focus on the 2 use cases from the AU Patient Summary, step 5 of the interstate GP visit and step 4 of the referral to the specialist in allied health. So as I said before, now we just want to narrow down on those. We've got so far with our community input, but there's still a few outstanding decisions that we need to get consensus on. Again, just reiterating, these are just use case examples. They're not mandates. We're just using these examples to illustrate concepts and workflows. We know there's multiple different ways that you can achieve the same outcome. We just want to keep working through these decisions together. So just reiterating that. So we'll start off with step 5 of the interstate GP visit consumer journey. So we had a bit of a brainstorm amongst the team on what we believe the intent of this step is. And we've come up with the following proposal. So what we're proposing is that this step demonstrates a patient summary that's authored and attested by the patient's usual GP, and that it's curated from their system's pre-populated data. It's also professionally attested. So that's an important distinction. We're talking about a clinical endorsement here. And that summary is retrieved via a link. So can I just ask, does anyone have any objections to what we're proposing? Are there any thoughts, any comments, any concerns? So I'm hearing none. So with that, I'd like to raise a motion to accept that we will be demonstrating a patient summary in step 5 that is authored, so curated from that pre-populated system, and that it's professionally attested by the usual GP, and that it's retrieved via a link.
We have some hands up. So,
Oh, yep, lovely.
I
Sanjeev,
will.
first.
Yep, Sanjeet.
Daniel, thanks for the comment, but just looking at it from a vendor perspective, what would it look like? Do we need does
Well, I think, and we'll see what Shelley says. I think the question that's being asked is, do we want to see what it would look like? And then we do an example and go, well, we think,
Yeah.
like if we have to do attestation, let's try and work that out in the example, rather than it proposing how it actually looks. This is more of a let's do an example that has attestation question. Brett?
Yeah, I'd just like us to not. I don't think we want to get into what attestation is. I know that was a shared health summary thing once that was a requirement. So if we wanted to say, yeah, it's kind of like if we want to do attestation, I think maybe we should just talk about how would you represent an attestation, and not say what an attestation is and what you are agreeing to, because it's that, yeah, I don't want to kind of, that's not our business for a start. And it's more
Yes,
just like
no.
if we have to represent it, like then I think you start to say, well, do we need to have a code that represents that type of attestation or something? And and then that's.
Can I just state here, Brett,
Yeah.
that FHIR has those answers on like what is the code, like professional, legal, etc. have a defined value set by FHIR. That's not up for grabs thing. So
yeah, but I don't want to weigh in on what the meaning of that is in Australia.
I think that's fine. I think it's is it useful? The proposal is to include that the patient summary is attested, and in brackets here professional, which will link, I'm sure, off to a FHIR code. And I think, oh, look, there's one in the chat. Yeah. Okay. That's off to the chat there.
That's good.
Rather than saying, what does that mean for Australia? Because again, I don't, okay.
Yeah.
I agree with you. I don't want to. B, this is an example, not a mandate. It can't define what it means, because this is just an example of what would an example look like if it did this, not defining what has to happen to do it. They are different things.
So all we're saying really is recording of attestation is in scope.
I think that's the good way of saying it.
Yes.
And only in scope of the example. Example is all this is about, not the rules in the IG.
No.
Cool.
So we don't have to say how you curate or how you attest.
Correct. Yes.
Right. Cool. Excellent. Cool.
Now let's go to Neil.
Yeah, I think Brett answered most of my concerns regarding that. My question is more whether not having attestation invalidates the patient summary and whether there are any medical legal consequences. But if it's, as Heath said, it's the recording of the attestation, then I'm fine with it.
And I think it's not mandatory as such. It's just this is an example of if it was attested that this is how you record it.
Yeah.
Exactly.
So let's just reconfirm here. There's a proposal here suggesting we could have an example. We can have an example that might show some parts of what attestation would look like when it's recorded. And that what it would look like in a document that's been authored from the GP, so it's provider authored, curated from pre-populated system, and retrieved via a link. Not necessarily, I don't think, being said that the exam. So we're not actually making rules about those things. It's just saying why don't we include those aspects in the example? So once we get past the, and they are absolutely things we have to make sure that we're not putting rules in that constrain or prescribe any particular way to do this. The motion, I guess, that Shelley's putting out there is, let's include these factors in that step. And I guess that is coming back then to the group to say, well, would you actually prefer there wasn't an example that showed what attestation would look like recorded? In which case, then, you know, we could say, no, don't even include an example, please. So I think that's kind of the conversation that is being posed. Neil, your hand's still up. Oh, thanks, Marvin. Neil, did you have a further comment?
No, sorry.
Okay, so we have a motion to suggest that the example that is associated with interstate GP visit patient summary retrieval incorporates some aspects in that example of the authoring, the attestation and retrieval filing as shown on the screen. That's been seconded by Marvin. Can I ask for other comments or questions? All right, I'm going to find the poll button. Let me do that. Okay, I've launched that poll for the current motion. Please vote affirmative, negative, or abstain. If you can't access that poll or see that poll, you can put your vote in the chat. And if you don't have access to either the chat or the poll, you can say your name and what your vote is, affirmative, negative, or abstain. Okay, we're just waiting. Only 65% of people have voted. We need some more people before I can close off that vote, please. All right, I'm going to count that down in 5, 4, 3, 2, 1. I will end that poll. With the vote in the chat, that comes to 19 affirmative, 0 negative, and 7 abstain. The motion carries. So the example will incorporate those aspects. Thank you, everyone. Back with you, Shelley.
Thank you. So we're fast running out of time. So we did want to pose a discussion question at this point, but we may hold the bulk of this discussion off to the next meeting. So what we're going to put to the group is, how is that interstate GP going to retrieve that patient summary? So is the GP going to use a direct tokenized link with full permissions? Is there an authentication server involved? Things like that. So what we might do is we might hold this over to the next meeting because we're not going to have time to go through that today. But that's just to prompt you guys to have a bit of think about that before we have the next one. So I'll move on. So on to step 4 of the referral to specialist and allied health. So this one's got a little bit more complexity, but here we think that the intent is that we're actually dealing with 2 patient summaries. So we've got the static patient summary generated at the time of referral, and then we also have the most recent patient summary. So when we look at the static patient summary at the time of referral, what we're proposing for this example is that we show a legally attested static summary and that it's attested by the provider at the time of creation. And we'd like to confirm that interpretation with the group. So does anyone in the group have any objections to what we're proposing? Any thoughts, any comments, any concerns?
Sanjeev?
Sanjeev, yeah.
Again, I'm struggling to wrap my head around attestation. I know this forum is not for looking at an implementation outside of FHIR. My question probably is, why are we even discussing it? Because I'm not aware how to implement it in my product.
It's a must support element in the composition profile. I think that's what's driving this.
Legally, the word legally, what does it mean also then?
Well, that's a different conversation. And what does it actually mean? We can just say in the example, it's legally attested and leave that entirely up to people's determination. But if that is something where like we don't even want to put an example in, then that's absolutely where we go here. Look, let's not do that. Thank you. I don't think that's good. And we might not be ready to even as you're pointing out, this one we might actually not be even ready to start trying to have examples around this.
Will CDG be okay with this wording?
So,
Yes.
Sanjeet, it could be as simple as the provider pressing the save button. That's attestation. Or could be attestation. But from the data perspective, the recording perspective, it is just a time and who did it and the mode.
I get it, Heath, but I'm talking more from a medical legal perspective.
I suppose it could, and Brett might also comment on this. From the perspective of what Shared Health Summary in the My Health record, there's a prompt that comes up, and that constitutes legal confirmation and recording of legal attestation.
Yeah, that's what I want to avoid, because I think this is like including patient summaries as part of a referral is normal, right? And like it's an authored piece of material that goes with the referral. And I kind of, what Heath is saying makes perfect sense to me, is it's something that's been authored and attested at a time to be part of a care provision kind of thing.
Well,
right?
it might
So
be
it's,
generated, but
yeah,
it's still
but
being
you accept it.
accepted, yes, by pressing the save button or the send
And that's
button
recorded.
or whatever, you know.
Yeah,
it's,
so yeah.
but
Which
it
is
is
normal.
it's a downstream thing when it comes to the My Health record. They will state their attestation requirements downstream.
Yeah, because that turned into something more difficult because they had other requirements attached to that attestation, like being the regular GP and a whole bunch of other things, right? So it like, I don't think it depends what the business is, how heavy that is, right? So it's
and let's be very clear, and I think Stephen's about to do that, regardless of what this example is, even if we say legal attestation, that means different things in different jurisdictions. The example is purely around a RESTful API and a set of data. What actually needs to happen in terms of legislation, requirements around wider system behavior that then somehow turns it into the data, this IG will never touch. Basically.
Yeah, I think we probably need to avoid sort of getting into those legal entanglement. But I think one point to reference to is if you look at the CDA document, CDA RMIM itself, it actually has a concept of legal authenticator there, which has a clear definitions of what legal authenticator means. We might be able to borrow some of the language here if we want to sort of make it a bit clearer, but I don't think that attested has sort of like the entanglement of medical legal connotations, but is kind of defined in CDA as who has the professional and also in quotes legal capability to attest a package of data. I think that we can. My suggestion is
the same in FHIR, Stephen. So that and thank you for that sort of concise summary, that has been brought into the FHIR standard, like taking those codes and adopting them. I think Steve has popped them in the chat, like the current definitions. And it is very, very similar. Heath?
Can I suggest we remove the word legally attested?
Yeah, I was going to suggest.
Just legal, just attested, static summary.
No, because we must. There has to be a mode. Mode is mandatory. We cannot say something is attested without saying how.
But it doesn't. We don't have to use the legal one. I think that's where Sanjeev's issue is coming here. Is that how do we do legal attestation? We can just do a professional as an example, or an official. I mean, just stay away from legal.
Then, to have a meaningful motion that will result in something productive, we need to say what kind of attestation if we're going to do it. So I am quite happy for a friendly amendment for this to be professional, or for there to be no attestation. What we can't do is try to have an example that shows attestation that is completely unknown what kind of attestation it is.
I think professional makes more sense in this case because this is just a referral, right? So there's no legal thing attached to it. It's just a procedural.
I think the meaning of professional looks right to me because it incorporates that press the save button or send button.
Yeah.
All right.
Even official
So-
looks scary.
In the time of official has to be an organization, so let's ignore that. Sort of. Well, yeah.
Well, no, the system, the organization can.
We've got 4
attest.
minutes left.
Yeah.
Is there a friendly amendment
There's
to
policies.
legal for either removing attestation entirely or to
No.
a friendly amendment for changing legal to something else and then insert your preferred thing here, please?
I vote for professional.
You would like a friendly amendment for a professional. Comments, questions on that? Is this accepted? Do people have other offers?
I think if
Okay.
it's the one that makes it
Okay.
most straightforward, then let's do professional.
All right, that sounds, and I'm seeing some other things in the chat that people are happy with professional. So let's adjust this to say professional attestation of a static summary attested by a provider at time of creation. Are you happy with that, Shelley?
Yep.
All right. Are there any other comments or questions on this point? Then I think you can make a motion, Shelley.
Oh, Marvin, were you about to say something? Or?
I
Nope,
just
I'm
muted
not.
Marvin because we were getting the echo, double back echoes.
Okay. Oh, sorry. So, yep. So I'll raise a motion to accept that we'll be just demonstrating a static patient summary that is created by the provider and professionally attested at the time of creation.
Thank you, Shelley. Is there someone who's happy to second that?
I'm happy to second that, Danielle.
Thank you, Sanjeet. All right, I'm going to go for the poll. Any other comments or questions while I'm looking for that? All right, I'm going to relaunch that poll. You should see that coming up for you now on affirmative, negative, and abstain. And this will be our last decision on use cases for today. The rest will need to be held over to a later meeting. All right, we've only got 70% of people participating, needing a few more to vote. Steve, yep, you've voted in the chat.
Yep.
All right. I'm going to count that down in 5, 4, 3, 2, 1. I will end that poll and share the results. And incorporating the value from Steve, we have 19 affirmative, we have 0 negative, and we have 6 abstain. So that motion has carried. And we will have the rest of the decisions in our next meeting. So in a fortnight, I think there were some other items, Shelley, that you wanted to walk through around use case decisions.
Yep.
All right, we're going to wrap this up pretty quickly because we're almost at time. So here's where we are. We've just finished this one. We've got 3 more calls in which we're going to do profile walkthroughs and look at changes. At the moment, the changes we've discussed really need to be driven through core and or base, looking at what's been raised, because that's where it's coming from. And we haven't yet identified additional constraints we want to impose. So we'll keep going. Next week is meds, guys. So we're going to be looking at meds. So medication, we're going to be looking at medication statement, medication request, and I think if there's time, we might look at allergy intolerance. So again, have a look at these profiles, have a look at the rules, and please come and identify what confuses you, what you think is a problem, what you think is a challenge, so that we can also tee up any of that feedback into IPS, or like we talked about today, making sure we raise issues and get that onto AU Core's agenda soon enough that they can change it in AU Core R2, because they're going to ballot for working standard in August. So there's a kind of a narrow window for change there, that if we do want to drive the change, we need to be kind of talking through it really soon. So that's really what's on the cards for us. Okay, are there any other topics then that people wanted to bring up, or any other questions or comments before we end the meeting today? All right. Thanks very much, everyone. I will see you in a fortnight, and we will look through some more profiles and some more example options. Thanks,
Just a
guys.
reminder about Conformance Friday, I guess, and
Yep.
I'll just put in the chat if people want to get there before it cuts off.
Sounds good. I'll see you at Conformance Friday if you're coming to that. I will be there. Thanks, everybody.
Thanks all.